my number one goal is to not have to prescribe medication, but I also see the need and see what they can do. You got to have counseling on board. If you don't have those tools in your toolbox, the medication's not going to be effective or be as effective as it could be for the best long-term outcome.
There's not less responsibility on the parents when you put a kid on medication, but there's actually more. Ultimately, if you really want to make success, you got to incorporate more people than less.
Because I don't want them to get a negative relationship with behavioral health care, because if it's something that they're going to have to manage lifelong, that's not in their best interest at all.
Hey everybody, welcome back to another episode of the Resilient Purpose Podcast. Today I'm really happy to have Janel Nuzum. She is a psychiatric nurse practitioner in the local area, and today we're going to talk about medication, and specifically the use of medication with children, some of the issues related to that, some of the benefits related to that, but just overall kind of its use and how it can use it in a very functional and effective way to help kids get their needs met. You left our agency right when I started, so it must have been something about me. But when I started in 2017 as CEO, I think you left when I was CEO. But anyways, one of the things that was really striking is not necessarily that you left, but where you left to. And is something that is not common and still isn't common to this day, which is going and working in a primary care office to a psychiatric nurse practitioner, which is what your specialty is, providing psychiatric care in a primary care office. So I am curious as to what precipitated that. I mean, there must have been some precipitating factors that said, man, really have the foresight to say this is something needed and be willing to do it. But then there also had to have been things that were kind of saying, this is out of my scope, or this is something I need help with. So
the model that we work from, what you just described, is called an integrated care model. Right. So my services are integrated into a pediatric and internal medicine clinic. Another word for that's kind of people on the outside might think as primary care. Right. But it's a little different. There's a pediatric clinic and there's an adult internal medicine clinic there. Mm-hmm. And the physician that I work closely with, that's Dr. Tomlinson. He's dual boarded, so he is certified in internal medicine and pediatrics. Okay. He felt like there was a big need in not only his practice, but just the area in general. He's trying to meet all of their needs in his 20 minutes. And you know that if somebody's got one behavioral health problem, that's probably going to take 15 or 20 of his minutes if he's trying to manage that. We had conversations just off and on. He said, what do you think? What would it take? I've seen this done more big cities, not rural. And we felt like we could make it work. It's been great. There definitely is need. Mm-hmm. The challenges, you said outside my scope, the challenges are I don't have counselors down the hall. Right. So, and you know this, I think that if we're going to treat, if you feel like medication is needed for most things, you got to have counseling on board. If you don't have those tools in your toolbox, the medication's not going to be effective or be as effective as it could be for the best long-term outcome. Right. So that need is certainly still there. And we've built a lot of bridges and connections, and I feel like we make it work. Well, it requires connections with agencies and really collaborating in some fashion so that there's an easy kind of referral process. So I'm curious because I have my views on medication and their use, and my first view of medication is that they're an adjunct to counseling, other types of intervention that are more primary, because we have to kind of change, because, at least from my educational belief system in terms of how we manifest these mental health problems, for the most part, through our experiences and through what's happened to us. And, there are definitely some genetic and, epigenetic type factors, but for the most part, those things are really manifested as a result of certain types of life experiences that have to kind of be worked on. The environment has to be affected. The genetic priming's there, but if we have enough stressors and the switches get flipped, then that expression's going to look worse. So going into the primary care and knowing that there's not really counseling, that there must be some barriers or struggles to kind of say, okay, I just want to come in and just give me the medication so my kid will be fine.
and then I can go back about my business and I can go deal with my stressful life and, try to manage things. Is that kind of like, do you find struggles in that area of, I just want the Medicaid, just give me something that works? No,
absolutely. And it's usually one of two things. They've either already gone the counseling route, at least from our internal referrals, if another provider within our practice is referring, because I feel like they do a really good job of identifying and saying, hey, you need to go try some counseling out, but we'll also think about referring you over for some medication management in a few months. Right. But if they've gotten to me, it's usually because they've gone down that path, and we're now having a conversation about what's the next step or what are our options. Or I do take outside referrals, so there are a lot of other area pediatricians refer. And that's often a conversation where I have to say, okay, yeah, your 10-year-old has some anxiety, but I don't think that it's significant enough right now that we need to start medication. What we do need to do is get you into 6 months of counseling and see what things look like. Gladly see you in 2 or 3 months and see how things are. Maybe circumstances change, symptoms change. But most of the time, a few weeks of counseling, we develop some coping skills, we get a better plan with school or home or wherever those bigger problem areas are. And sometimes they come back and they say, hey, we're good. That's the outcome. So we're not far off on,
right.
My number one goal is to not have to prescribe medication. But I also see the need and see what they can do.
So can you elaborate on that? Because I think that's important maybe to distinguish or clarify that your number one goal is to not prescribe medication. Number one, why is that? And number two, how do you see a need if your number one goal is to so there has to be kind of a reasoning of when medication really is necessary or is a good option, and why we don't really want to kind of push that first.
It's risks and benefits. So I would think in most circumstances, we could sit here and weigh out risks and benefits, and counseling is going to have a lot less risks than any medication. Even if I can tell you that something's generally pretty safe and well tolerated, I have to tell you that there's risks.
Right.
There's not a lot of risks to counseling.
I've heard medication commercials, and those aren't really fun when you hear the list of side effects, especially when you're thinking about your kid. The way someone reacts to a medication is not the same as, everybody's not the same. Yeah. So we don't know theoretically until we see how it works, but we have a good idea of. Yeah,
I can tell you the top things or what I've seen the most, but no, we don't know until we try. And we could have an opposite effect. That's not what we want. At the same time, though, and this is where it gets kind of a little differing in opinions, I think, they can be life-altering in such a way for kids that if they, ADHD is a pretty easy example to work through. So it's 3rd grade. We're not able to sit still. We'll just do a classic presentation. They're not able to sit still or focus. They're disruptive. Teacher's trying, but at the end of the day, they've only got so much energy that they can put towards managing a classroom. So this child's getting in some trouble. They're being sent out, or recess is being taken away. Grades, they're not performing academically. Right. So now they have, even if there's been a plan put in place, now they have a negative association with school.
Sure.
That keeps moving forward and snowballing and turns into 5th and 6th grade. They're doing even worse academically. They're maybe not making the best choices, maybe dabbling in some substance use as we go on through middle school and entry into high school. And then we get all this other fallout, depression, anxiety. And yes, we could have had them supported in counseling. The majority don't. They're not coming to see me when that's going on.
Right.
But then they show up, and what happened was we had an opportunity to potentially intervene. And ADHD is probably the number one diagnosis where counseling's only going to do so much for most of those presentations. And if we'd started medication earlier, by about age 10 usually, huge difference in what that outcome in adulthood could have looked like. Doesn't mean all's lost. We can still make lots of improvement at that junior high level. But I know that had we had the opportunity to start a medication, that child's path and their school history, their potential, all of those things have been greatly altered. So that is where I think it's just really important to always have the conversation, a thoughtful conversation. Is the medication a good idea? Is it not a good idea? Should we do it in continue counseling? Should we think about supporting them in occupational therapy? There's all sorts of other services that might make a big impact.
I think your point highlights a couple things. One is that there's some systemic issues, especially in like the educational system, where what you're describing is developmentally kids are behind for whatever. They just don't have kind of the core regulating processes in their brain that are organized well enough to kind of manage the expectations or demands that school places on them. And because we don't necessarily adjust to that as teachers or schools, or even have the level of human support, like one teacher to 20 some kids, the kids fall further and further behind because they are never able to catch up. It's kind of, I was doing a training today, just talking about that very issue, is that because our kind of systems are not geared towards the variance in development, we're not able to meet those needs. And so where I would say is that medication often is needed that early because they are having to survive. They're having to survive an environment that their brain doesn't have the capacity to survive, like in terms of what demands are being placed and how they are able to manage it. So we have to regulate them enough to where they can tolerate what is being intervened. And when they get to junior high, they're really behind. Yeah. And so then it becomes really concerning, and we're like, oh, we gotta like kind of figure.
Yeah, well, you got hormones and everything else going on too, which on its own is hard, and then it just upends
don't
everything.
Remind me, I have a middle school child right now, so it's it's got me.
Yes, I've got the 8th grader with the first girlfriend.
Oh,
we're
nice.
We're surviving. No, so let's keep using ADHD as an example. Emotional dysregulation, we know, is part of that symptom subset, right? So we've got a finite number of resources in the classroom. They're developmentally, because they can't emotionally regulate, if we're not even thinking about focus or hyperactivity.
The inattentive side of it.
Yeah, they can't emotionally regulate. And we're asking them, like you said, to do these things. What then happens to all of those interactions with their peers and teacher? They can't cope, and so
it reinforces a lot of negative experiences in that environment and leads to more problems and more difficulty.
And so there are things that exist that one of the first things I say, if we decide that ADHD is the diagnosis, is, do you know what a 504 plan is? Because teachers have resources. Sometimes they're limited on what they can ask for if certain things aren't specifically documented, and it depends on the school and
it is
the
very
principal.
school specific, because some schools have lots of resources, some schools don't, depending on funding and availability.
And I think 9 out of 10 teachers, they just do it. They make the accommodations, they modifications, they know what's going to help a child. But it helps to have it written down and formalized. And so,
well, it at least kind of guides people, or at least helps families have a place of reference to say, this is what my kid needs, and this is what's been recommended to help my child get better.
The difficulty is getting that plan executed.
Absolutely.
I feel like a well-executed 504 plan is a rare thing. But I think they try. I don't want the education system to think that we don't feel like they're trying. They are. Resources aren't there.
Well, it's not because they're sitting there going, I don't want to do this 504 plan. It's because they're balancing 50 million plates, and they're trying to, because we're under-resourced probably. I'm guessing, I mean, correct me if I'm wrong, but you're not just kind of sitting at your office kind of twiddling your thumbs, listening to podcasts. I mean, like, you're pretty busy.
Yeah. You're either seeing a patient or fielding a phone call, or something's gone wrong at the pharmacy and they don't have this, and can we do this instead? Or so-and-so showed up and it wasn't their day. Will you see them? Yes. Go ahead. Squeeze them in there. Something's going on. So everybody is trying to multitask, but kids are kind of getting left to fend for themselves.
Right.
And we need to make sure parents know what their options are.
I'm curious, especially with kids, if a lot of physical stuff that they were going to the primary care doctor turned into just kind of they're having like physical health problems, and then you can't really find a cause. Is that kind of something to kind of link to?
I think definitely anxiety is much more prominent in the pediatric setting or age group, and probably presentation wise in the primary care setting. Depression is also there. That's not as common. But those are often the individuals that will come in with those types of complaints, and they're trying to run those things down. Lots of stomach aches, or we've got headaches,
digestive issues. They're getting sick a lot, or headaches. Yeah,
or lots of reasons. Separation anxiety, or we've got some social anxiety, and we just always don't seem to quite feel right when it's time to go out the door, or the bus is there, or we get to school and we've got all these calls. Need to come home, and they're trying to figure out. We've got, maybe it's chest pain, or it's not really chest pain. They're anxious, or stomach upset, or we're making 10 trips to the bathroom when it's time to go, and they've got, and people come and say they got a nervous bladder. It's anxiety. They're anxious about whatever it is you're about to take them out and do.
The other thoughts that was popped into my head as you were talking about kind of the benefits of using medication, but we're going to try 6 months of counseling, and I just know kind of running an organization like this, and that the demand is far greater than the supply that we have of providers. Do you have any thoughts in regards to the frequency of intervention that you see? I even think of an ADHD. They would benefit greatly from OT, and we can talk a little bit about kind of what OT is and why it's beneficial for ADHD, but then the amount of repetition that a kid with ADHD could get doing kind of OT-like interventions, movement interventions, things that are going to help regulate those lower systems that make it hard for them to pay attention and focus and regulate, they're probably not getting enough. And so unless all the environments that are at play, home, school, or wherever, that if we're not all doing those types of things on a consistent basis, we're not making very good progress. And then it, to a certain extent, might look like, there's more need of medication because we're ending up not really this isn't working. Well, maybe the frequency and repetition isn't there because maybe we're lacking the resources, or we can get OT in the school, but it's going to be once a month for 5 minutes. Or
it's more complicated than that. I think you have to educate the parent. So ideally, I'd like you to go to counseling, and once you get in there, and it might be 6 weeks before you can get your first appointment. I hope it's sooner. Ideally, it'd be every couple of weeks for a few months. And then if the counselor's seeing improvement, maybe they then pull back the frequency. But you and I both know that counselors don't often have that on their caseload. OT, sure, we could say, there's a need and the school provides that service. But most kids would not screen in to OT services.
Not in the school system.
Not in the school system.
Right.
But then you have to educate parents that you can go privately. There's certainly services that we could get them. That we could get them in. What we talk. When you get, it's often harder because the private insurance, those rates are going to be way higher. They're
going to be way higher, and they only cover so many, and
only so many sessions, and then it becomes a bit of we've got this gap in need, and trying to find them different resources. OT, I feel like, is so underutilized, though, and especially for if there's hyperactivity, if we are rushing to get through our handwriting, if they're struggling to stay in their seat, even focus, multitasking, multi-step directions.
So let me ask you, we haven't really explained occupational therapy.
Yeah, let's back up.
It is such a weird name, just by the way, occupational. Most people would think that, okay, I'm giving you therapy about your job, but that's not what it is. So can you kind of explain what occupational therapy, because I know what they do. I don't necessarily know why they call it occupational therapy, but.
So occupational therapists think about like waist up is kind of what they would probably tell you they specialize in. Lots of us know physical therapy. When you get your ACL repaired, you've got to go see a physical therapist for so long. So they're kind of waist down. Occupational therapy is going to do anything that has to do with if you had an injury and you're regaining strength, hands, arms, upper body. But they do other things that if we had an occupation or job, child's jobs to go to school or to do whatever they need to be doing at that age.
Right.
They can work on those age appropriate skills, tying shoes, writing. Are we able to neatly write? Or maybe sometimes not even neatly, sometimes it's just, is it legible?
Right.
You've got kids that shut down in the classroom because it's too much effort to get it written out, but they could orally give an answer. But if we send them to OT and they're like, oh, just try a slant board. Oh my gosh, that demand is so much less, and they can write tons more.
So they can recommend tools that'll help you do that in the classroom, but then they can also work on skills that they need to kind of build, because there's some lagging skills in certain fine and gross motor skills. And
occupational therapy is where the sensory integration disorder treatment lies also. And a lot of people don't know that. It's kind of a hidden skill.
Right.
The occupational therapists that I know work magic. They're able to figure out sensory seeking, where kids are looking for an experience, or aversion, where they're trying to stay away from a certain experience that we didn't even identify that the child had. We might have known just a couple of things, and they put them through some different, nothing scary, tasks to see if something helps them regulate their mood or makes them more upset after they have been through that sequence of events. And then they're able to come up with a whole list of things that parents can do, school can do, to help the child regulate.
Well, that's the key, though, because you need the repetition and the activity to be done in other environments. That occupational therapy at the, say, half-hour appointment, 1 day a week, just isn't going to cut it. Not if you're trying to make real progress in a real amount of time.
No, and that's where I think that 504 plan can really be helpful. I could see somebody and I could say, this child might really benefit from jumping on the mini trampoline for 5 minutes every 45 minutes or so. But I don't have as much teeth to say that that's an appropriate recommendation as an occupational therapist would. So I say, go see the occupational therapist. Let them come up with 10 things that the school might be able to do. And let's get that put into that 504 plan so that we can help them regulate, and they can figure out what works in the school day, what doesn't work in the school day. 'Cause just because we have one recommendation, it might not be feasible at all with the resources that they have, or the way the school day is structured, or if there's 5 other kids that have the same need, maybe we need to come up with a few different things.
So there is a doctor out of Nationwide that we've been kind of interacting with as part of we have a partnership with a group called Partner for Kids, and they're kind of like an accountability measure to make sure kids are getting the help that they need. And it's more related to people on Medicaid. It's out of Nationwide, and Nationwide has this child psychiatrist, and I'm blanking on his name, so I apologize, doctor at Nationwide. He had a great hashtag, more skills, less pills. And that's coming from the chief medical director of Nationwide Children's, kind of saying more skills, less pills, which kind of goes back to kind of my sometimes aversion to the use of medication, because some of this can kind of be really related to skills that need built, and medication is not going to build social skills. The idea behind the medication, it's going to get you into a place where you can learn those skills. Like, it's going to regulate your system well enough to where you can respond to that skill teaching. And can you explain kind of how you navigate that with people? Because I would imagine that there's an expectation that all my problems go away because I took this Adderall or this, Paxil or whatever, medication for whatever treatment issue.
Delicately is the answer. You have to lay a really good foundation from the beginning. So at day one, if they're able to hear you, sometimes people are
so desperate in that moment.
They're just not able to hear everything. But day one, you start with that foundation. This isn't everything. This isn't going to fix it. It's not going to 100% resolve it. It's going to make things better, I hope.
Right.
Like you said, I don't know until I try. I don't have a test that tells me exactly what's going to work for you. The goal is always less or none, ideally none. You always reevaluate. Do we still need this? If we're treating anxiety or depression in a 12-year-old and we're a year out and things are better and they're plugged in with counseling, they're back at their usual activities, they're sleeping well, mom and dad are, thumbs up, this is good. You start to wean off. And that's the goal.
Right.
You don't want to have to
short
continue
term.
medication.
It's not designed to be a long-term
everything.
solution.
Even bipolar disorder. So new research coming out in kids, we don't even diagnose that until they're 15. But new research coming out that we say medication for life, right?
Oh, that's, there was definitely kind of statements that bipolar, you can't survive without medication. Like you have to be on it and that's a disheartening thing. You're like, kind of like,
depends on the severity, right?
Or how long it's gone before left untreated.
Yes. But new research that if it's treated early and treated well, you might not need medication for life. That's huge.
Yeah.
We used to tell people, oh, that was it. You have this diagnosis, it's this, or you're not going to have any sort of function in your life. Right.
Which is, that's a tough place to be.
It's kind of optimistic that we could maybe make some interventions and improve what the long-term outcome would be.
I'm curious. I would be curious to kind of hear more of that research, because it'd be interesting to see what was kind of done to kind of show that. I would imagine that there's, things that complement kind of what was used to get them to that place. There's not less responsibility on the parents when you put a kid on medication, but there's actually more responsibility put on the parents, the people involved in this kid's life, not just parents. I mean, ultimately, if you really want to make success, you got to incorporate more people than less. If it's just a parent, you want to, probably the first thing to do is wrap more people around that person. Like recognizing, okay, we start putting medication into your kid's body, that there's more responsibility to do things.
Yeah, no, absolutely. One of the first conversations I have is until they're 18, even if we have a responsible teenager, they are not solely responsible for taking their medication. You have to observe it. You can have them learning the skill. They're going to go get it. They're going to take it in front of you. They're going to put it back. That's fine. They're learning a skill, but you're actively involved in that process. There's probably no more just popping over to grandma's, and grandma's got to know what's going on, or, sleep over. Somebody at school, I encourage them to let somebody know, even if it's not being administered at school. I'll usually say, is there somebody on the adult level that you're okay with knowing? Counselor, is there a teacher, principal, somebody? And then I encourage mom or dad to make that connection before they return to school. Just because we don't know, especially when we start medications, it's not usually feasible to keep somebody out for a week or two. They could, the better thing for them to be is in class and as engaged as they can be. But there could be things that develop that I would really, really, really want somebody there to know, so that they could have some idea of what's going on in their life. You
really kind of have to make a concerted effort to build those skills, to get them more help, like to make sure that they're getting intervention that can allow for that short-term use of the medication to happen, to actually be a reality. Does the people involved in this kid's life factor into medication usage? Like, do you start saying, okay, well, let's get more supports in this kid's life before we start kind of making those decisions? Or is that kind of a concurrent thing? Or
I think it depends on the presentation. I think if I had a child that I was not sure there'd be any consistency in things being administered, yeah, you definitely want to have a much better support system or plan in place. And sometimes that's a school. Sometimes, the reverse is true there. We have the school administer medication when we can, or say, you spend most of your weeknights with grandma because mom's working third shift. Could you bring grandma in so I could talk to her? I really feel like grandma needs to hear me say these things. I trust you, Mom, but really, if grandma's going to be the one giving it, maybe she should come in. Just like when you take that initial history, right? You ask, who can you talk to? Who are your 2 or 3 biggest supports, and why are they your biggest supports? Those social determinants are so important.
A lot of these appointments are initiated by the parents. Very rare that a 6-year-old or a 7-year-old is going to say, hey, I need medication. I need to come in and see you. So a lot of these efforts are put forth by not the kid who's going to have to take the medication, deal with the side effects if there are any, or just know kind of all that. So what is that process like? And because, these are things that, like, parents are saying, I think my kid needs to take medication. Sometimes kids are like, whatever, just, take whatever anybody tells me. Or some kids are going to really struggle with that idea. Or how do you navigate that?
I think it depends on the presentation. So there are things that are absolute line in the sand, right? No, you don't have a choice, Joey. This is something that just needs to happen, even though you try and get some buy-in from them.
Right.
But the goal is usually to look at Joey and say, this is why I think it would help you. This is what could happen. And what do you think about that? Most of the time, I would say parents have had some type of a conversation with the child about why they're coming. And it tends to go okay. But there comes an age where I've had to look at a mom and dad many times and say, you can't sit them down and make them take this anymore.
Right.
This isn't an option. Now, I'd like to talk about what other options could be, but sometimes, they're allowed to exercise some agency. And if they say they want to try for a few weeks without, let's try without and see how things go. Because I don't want them to get a negative relationship with behavioral health care. Because if it's something that they're going to have to manage lifelong, that's not in their best interest at all.
What are some of the common presentations that you're getting in your area, or what are you seeing? Or is there anything kind of that seems to be like more patterns of things that you're seeing that are more collectively across the community, or just things that seem to kind of be increasing over the last couple years?
Pre-COVID, I would have told you my pediatric population was probably predominantly ADHD assessments, anxiety, oppositional defiant disorder, which there's no medication for, but I would love to get you the services.
They would wish, right?
Yes, they would wish. If it runs with something, we know it goes with ADHD pretty often. Sleep problems, which most of the time isn't something we start medication for. It's more education and trying to approach it that way. During COVID, post-COVID, anxiety. Kids just did not do well. A lot of ADHD referrals, some were appropriate, some weren't. Kids thought because they were at home trying to learn that they suddenly had an attention problem. Most of them, it wasn't something new. It just wasn't a good modality for them.
Right.
Adults right now, there's still just a lot of anxiety. I feel like we thought when everything kind of opened back up and masks went away that everybody had already come out of the woodwork.
Is it anxiety related to catching COVID, or anxiety that this is never going to go away and my life's going to
I think their coping skills were uprooted. So a lot of them are new to treatment, or had a big break in it. I had anxiety problems 20 years ago, but the last 18 months, 2 years has just really exceeded my coping skills. We
have this concept that we talked about in the neurosequential model therapeutics, where it's kind of like you kind of look at this kind of bell curve, and you have on the right side of the bell curve, you have people that are pretty hardy or resilient. They just can tolerate a lot. They don't get too stressed too easily, so they can tolerate a bunch. And then you have a majority of the population that is, kind of normal stress levels. They can tolerate the window of tolerance is theoretically normal, right? I don't know how you define that, but they generally can manage in life. And then you have that other end of the left end of the bell curve. You have the vulnerable, the people that are so sensitized that any sort of stress, any sort of dose of stress overwhelms them, and which leads to the anxiety and the depression and things like that. All those mental health problems that bring those people into care, and also leads to a lot of physical health problems as well. They start having they get sick a lot and all those types of things. So one of the things that we kind of talked about, or Dr. Perry talked about, is, because their stress response system is so malleable, that you have the resilient people, because of what's going on with COVID, lose that resilience because they're experiencing all this unpredictable, severe and prolonged stress. It kind of chips away at their resiliency. And then you have a lot of the people that were kind of typical become vulnerable, and so now you're getting an influx of people that are, needing help because they used to talk they don't have a history of mental health problems. They don't have genetic predispositions, but life circumstances, because it uproots them, creates this vulnerability and this sensitization, and now they don't know how to recover.
Those individuals are much harder to have that initial conversation with, because they just don't, they have no point of reference.
Right.
Like, this is not something I've had to deal with. I don't understand what's wrong with me. This has got to be something that's just, horrible. It's never going to get any better. And it's so treatable. We just got to get you plugged in.
And then, of course, the biggest worry is the people that are already vulnerable. How bad is it now? And is it making things, just becoming so unbearable and things like that? Is there a mindset or a logic that, well, the medication's the reason why I'm doing well, so the idea of taking medication off seems to be kind of not right, because then I'm going to fall apart. What's responsible for my success? The medication's responsible for my success, and it's not any of this other stuff that I'm developing. How do you get people to kind of that realization that I can come off that medication? Because, for the most part, and I've worked with kids for 20 some years, 25 years. I know, at least in my recollection, it was like, this kid needed this medication, and the idea of taking them off would be so destructive that you don't even like. And so like the thought of, they just kept adding medications, let alone taking medications away.
No. Sometimes you need a clean slate.
Right.
So you have to lay that foundation. And again, it might not be on the first day, because they might not be ready to hear you then. But if they're doing well, you start saying, you've had 6 months of stability. If we have 3 more months, and this is probably a depression, anxiety presentation, we just lower it a little bit and we see how you do. If things get worse, then maybe we go back on to, nothing is set in stone. There's no hard and fast path that we have to follow. I can tell you what research says with recommendations, but just like I didn't know how you were going to do on this, I don't know how you're going to do tapering off.
Right.
But we'll get back together and figure it out. I generally don't taper quickly. It's usually a very slow process. And then I continue to see them for a series of visits even after, just to make sure they continue to do well. And some people say they earn it, right? You try and wean them off, and 3 months later, anxiety's back and they've lost function. They're not able to go to school or do their social events. Okay, you earned it. We'll just put you back on. You tolerate it well. There's really no long-term poor outcomes from being on this. For you, the benefits outweigh the risks. But the goal is always to try and the lowest amount of a single medication, the lowest number of medications, and ideally none. I
just remember when I first started at Life and Purpose, and we would have a group of folks that were MedSum only. And the MedSum only would mean that they're not doing counseling services or just getting medication. But every year they would have to get a diagnostic assessment update. That's just part of the regs. You have to just kind of get that assessment. We would see that MedSum only, and you'd see all these kind of like changes because they're just trying to kind of catch them where they're at. And then they would still be describing all these environmental issues or ecological issues and problems and things like that. I'm like, I think therapy would be great. I think that's something that probably would really help improve things. I think I'm just going to stick with that. I just see too much of kind of like unintentional consequences that come from just going to the medication too quickly, or because something's not working or whatever. And we're just kind of, for lack of a better word, impulsively kind of choosing that and not strategically or having the right purpose of why I'm using this medication, for what purpose and how long, and what am I going to do while this is happening.
Let me give you a primary care example. So not that my primary care providers in my office would do this, but 10-year-old shows up with anxiety, and there's legitimate anxiety concerns. They can go through symptoms. They can check off nice, neat boxes. So let's start some Lexapro and we'll see you back. And if things improve, then we'll just leave it at that. We won't do anything else. They come back. Nothing's really changed. Well, I know you have anxiety, so I'm going to leave you on this or increase this. But now I also hear a problem that maybe you have some concentration problems. Well, that could be anxiety, but it could be ADHD. So why don't we go ahead and treat the ADHD? So now we're on 2 things. And maybe amongst that, there was a complaint of sleep. So maybe they treated the sleep too.
Right. Well, yeah.
Maybe the only thing going on was 2 things. Maybe they weren't sleeping well, and all that parent needed was some education on how to get them on a good sleep routine so their mood would be better regulated and they could focus in class, and then they wouldn't have all this anxiety because they weren't doing well in class. Or maybe they had ADHD and we were treating anxiety. But the med never got stopped because, well, they have anxiety symptoms, so they must need it. If we'd assessed what was going on, maybe they needed no meds, maybe they just needed something for the ADHD, and we would have had a completely different risk profile for what they were being treated with.
You're emphasizing the importance of a good assessment, because a stressed out parent who's really lost at their wit's end might not be able to see all the things that might be contributing to it, and just kind of like, it's just something wrong with his brain.
Do you know how many times I recommend that the parent get into counseling as part of the treatment plan?
I'm guessing a lot.
Yeah.
Yes. Yeah.
Yeah. No, this would look a lot better if you sought some services out for yourself. It's a hard sell.
We're getting better as a society to kind of recognize that it's okay to get mental health, and that doesn't say anything about the quality of who you are. I'm hoping we'll get better. I know we're not where we need to be, but
it's better.
Let's
go with that. It's better.
Right. And so I guess my question is what is the sell, and why do you come to that conclusion that the parent needs to kind of get some support for themselves?
Yeah. So a lot of times what's brought them in is because things are uncomfortable at home. Mm-hmm. They care for their child, but things are uncomfortable, whether they're managing meltdowns or they can't do the activities they want to do because the child doesn't tolerate it. Right. Or if it's older kids and we're maybe not making the best choices, and then there's fallout from that as far as behaviors and maybe probation and all those other things that can happen.
Yeah.
What if you could fill your toolbox up with more tools? That's not a bad outcome for anybody.
Right.
And if you had another way to approach what was going on, the long-term outcome and your relationship at home might look completely different. That's the sell, is that it's good old-fashioned family systems, right? But nobody, they don't.
Right. We're not suffering in isolation. We're everybody's affecting everybody. So if we can work on ourselves, and kids getting help, and mom and dad are getting help, and siblings are getting help. I mean, there's a kid family that I'm working with right now. Like, everybody has had to pretty much go into counseling because, there's just a lot of chaos and stress and things like that. Because ultimately you're just going to have these really like time bombs kind of hanging out with each other, ready to go off. And it's going to hurt the relationship. It's going to make it worse, and it's going to make it hard to come back and get to that point. And then that's going to be more likely to lead to a kid to be on medication for their lifetime, because definite areas that could, if they resolve this, would probably reduce that anxiety, reduce that inattention.
And I think that goes back to what we were talking about in the classroom, right? There are times when our symptoms exceed our coping skills. And if our symptoms are exceeding our coping skills, we might be more likely to be on medication at that point. Mm-hmm. But that's not a terminal outcome, a terminal state, if you will. That can change. So if in third grade, this child was not doing well, they emotionally weren't stable at school, we were having problems at home, but things got better. Maybe in fifth grade, now our coping skills exceed our symptoms or our environment or our circumstance, whatever those other external factors are, and we don't need medication anymore.
Right.
It can be this different series of levers, if you will, that go up and down.
And I don't know, like, I can kind of conceive, this is why I like the schools, like that we work in the schools, and we have a lot of staff that are doing a lot of intervention there, and we have different levels of intensity of programs. But I think in situations, also in providing good training for teachers in this area, oftentimes what we are talking about is literally that kids keep progressing in school but are developmentally further and further behind. So they are not matching. So we continue to provide instruction that is developmentally beyond their capacity. As long as we continue to give them doses of demand that far exceeds their window of tolerance or capacity, we're going to continue to see challenging behaviors. The majority of their life is in school. Kids' lives are in school, so they just happen to be not the target, but the environment that we're going to spend most of our time and see most of the problems. I do training with schools all the time. Like, I was open house at my daughter's junior high, and the teacher, although he didn't seem disgruntled or discouraged by it, had like 25 kids in each of his class, 25, 26, 27. It's just him. Hopefully there are 25 regulated kids, but that's...
You know the statistics on that, right? That's not the case.
Right. It's not the case. So one of the things that I want to impress upon people is that we also have to change systems. in environments and support. So like Ohio is doing great with putting a lot of money into the state, into the educational funds and stuff like that. Are they being used right? Are they being used things to make more developmentally relevant instruction in environments so that kids can get that opportunity to jump on the trampoline because that's what they need, or to swing, because that's what they need. And so that can help catch them up and can improve their attention, their focus, and less need for a stimulant or any type of, medication in the long term. And that's kind of where I think unfortunately, it's a complicated issue because there are so many factors into this issue.
Well, I don't think it's any different. If we're asking parents to be better regulated and build their toolbox, it shouldn't be any different than to ask the school, the teacher, or whatever that team is there to better support them too. Mm-hmm. It's all part of the same team. The child's best interest is what needs to be there. Now there are things that, we don't have and we're not going to have, but right. There should be something that fits the need.
Absolutely. And I think part of that involves just being open and flexible in terms of how you use your resources and what you look for.
Well, and I think this happens a lot. Child's on an ADHD medication. Mom or dad show up halfway through the year. Teacher says 2:00, we just don't seem to be doing well or not doing well all day. Mm-hmm. Okay, so we get the rating scale from the teacher. We look at things. Yep, they're definitely saying that there are symptoms there. But I don't have anywhere to go with the medication maybe for that child. Maybe if I increase it, no, they're not eating or they're not sleeping or they're just really irritable when it wears off. Okay, so what are we going to do to fill the gap? Because I can definitely see benefit when they take this, but I can't do anything with it right now.
Well, and then looking at that schedule, what's their schedule like? How much movement did they get during the day? How much break did they get from the heavy academics? Like, people get worn out after, that day. I can't even think of like my kids getting a whole ton of homework after a long day of academics, and I'm like struggling with my kid to get them to do homework because they're exhausted. And I don't want you to do this homework any more than you want to do it. But what am I going to do? It's part of your grade, and all that thing is like developmentally. It's like we're not thinking clearly. We're thinking, we're giving this homework. The advanced kid can handle it, so everybody else should be able to handle it. And you're just like, no, they should. No, that's not how it should be. That very example you bring up is a real example of one where the kid broke down at 2:00 every day, like major meltdowns, like huge behavioral outbursts, problems, running away, all those types of things. The kid was holding it together. He's having to work so hard to stay regulated, and impose himself into this point to where it just eventually exhausts him and he can't tolerate anything anymore. So what do? We change the schedule. We break the schedule up in smaller doses. We incorporate lots of regulation throughout the day so that they can kind of do those things. And luckily the school is flexible enough to be able to do that. You could see those patterns, it's like, every day at 11:00, guess what? He's had an hour and a half of math and an hour and a half of English.
And what you don't know on my side is I'm telling mom or dad, okay, give the medicine an hour earlier or an hour later a couple of times and see if anything's different.
Right.
And if the answer is no, it is just that they have surpassed what they can do. Mm-hmm. We've got to make a change.
Right. Well, and sometimes you might find, I don't know if you correct me if I'm wrong, but sometimes the medication kind of rules things out mm-hmm. to a certain extent, right? Like it's, okay.
Well, it can become a constant, right? And I can adjust and I can see if things are changing. Right. And if they're not, then I can much more comfortably say, we have to change something that's supportive. It's not right. It's not a medication need.
Right. If we're seeing no progress on any of the medications and we've made all the adjustments we can make, then we have to come back to the drawing board and figure that out. What are you looking for to accomplish when people come to your office? Like, what's your kind of hopes or?
You always want people to leave feeling like they were heard and that they've got some kind of plan to address whatever they felt like was a problem. Mm-hmm. Sometimes that first day, it's not a very detailed plan. Right. It's just that you hope they come back. Mm-hmm. But I think that's probably the bigger thing, is that you want them to develop a therapeutic relationship with somebody so that they can continue to work through it. What you went back to with, do you ever feel like They just want you to give them medicine. Yeah, absolutely. But that's not always what's in their best interest. What's maybe in their better interest is that long term that you've established you've got a behavioral health care need. So let's talk about what that means. And if that means you've got to come see me once a month for 6 months until I can convince you to go to counseling.
Right.
Okay, we can do that.
We'll work at your pace.
Yeah. So you got to meet people where they are. Because if I turned everybody away, that when they come through the door the first time and they're like, if you're not going to give me medication, I don't know why I'm here.
Yeah. You got to hook them somehow.
You got to get them in there somehow. So, okay, we'll do this one thing today. Then we'll make sure that we're following up with a really well executed treatment plan that includes all the supportive therapies.
Well, and one of the things I'm really happy about in terms of having this conversation with you today is that the worst time to solve a problem is in the middle of it. And so you were getting people in the middle of a problem. And so it's hard to think clearly. It's hard to use your cortex to come up with effective solutions. So you're just looking to kind of, get an answer quick. I'm hoping that this kind of provides a resource for people to look at when they're not in the middle of the problem, so that they have kind of a good understanding of why we use medication, for what purpose, and what's our overall goal in terms of how we work with kids and just people in general.
Yeah. So. And it's not a scary process. It's not all that different than what you do with a counseling intake. It's a conversation. Right. I'm going to ask you about your medical history. I'm going to ask you about your symptoms, your support system, all of those things. And then we're going to have a thoughtful conversation about what might be helpful and what might not be.
Thank you. I got through this without completely hacking out my lung or whatever. But I appreciate you having this conversation. I always enjoy talking to you. And now we get to present our conversations to the world. So I appreciate it.
Thanks for having me.
All right.